Today I would be giving a brief talk on pediatric inflammatory bowel disease. What is it and how is it different from adults? I would be telling you about diarrhea from a pediatrician's perspective, causes of persistent and chronic diarrhea in children, pediatric IBD subgroups based on age of onset, pediatric ulcerative colitis and Crohn's disease, a bird's eye view of its diagnosis and management, and summarize the difference between pediatric and adult IBD. Now, a recap on classification of diarrhea. Acute watery diarrhea when it's less than 14 days in duration. Acute bloody diarrhea, also called dysentery. Persistent diarrhea, that is more than 14 days but less than 4 weeks, usually infective. And chronic diarrhea, that is more than 4 weeks, it is recurrent and usually non-infective in nature. The etiology of diarrhea could be osmotic, secretory, inflammatory, or malabsorptive. And if you talk about persistent diarrhea, 10% of all diarrheal episodes in children are persistent. 60% of children with persistent diarrhea are below 6 years of age, 90% below 1 year. And among patients of malnutrition, 20% of their diarrheal episodes go on to become persistent diarrhea. The common causes in children are infective, bacterial, protozoal, and viral. And an important part it is also due to carbohydrate malabsorption, that is secondary lactose intolerance, seen as a result of persistent GI infection damaging the gut mucosa. So the chronic diarrhea causes are nutrient malabsorption, carbohydrate malabsorption like lactose intolerance, fat like in cases of cystic fibrosis and Crohn's disease, protein as in cases of cystic fibrosis, trypsinogen deficiency, enterokinase deficiency, abnormal digestive process as in cystic fibrosis, immune and inflammatory as in cow milk protein allergy, autoimmune enteropathy, structural defects affecting electrolyte metabolic transportation, and infective bowel disease, and motility disorders like Hertzsprung's disease and chronic non-specific. A very interesting picture I came across. Chronic diarrhea has 5 C's, could be cow milk protein allergy, colitis, Crohn's disease, celiac disease, and cystic fibrosis. Now focusing on the inflammatory bowel disease, the Crohn's and ulcerative colitis both are characterized by unpredictable exacerbations and remissions. Etiologies are unclear, but the onset is bimodal, first peak in 10 to 20 years of age and a second peak between 50 to 80 years, and approximately 1/4 of the presentation is before 20 years of age. Now the subgroups, if pediatric IBD, when the onset according to Montreal classification A1 is below 17 years, early onset is below 10 years, very early onset below 6 years, infantile onset below 2 years, and neonatal IBD in the first 28 days of life. Now, in a publication from northern India, Poddar et al. Among cases of pediatric IBD report that majority of the cases are in the age group of 11 to 15 years. The gut involvement in ulcerative colitis, the inflammation is limited to the mucosa except in toxic megacolon. In Crohn's disease, involvement is often transmural. Definitive diagnosis is not possible in 10% and it's called indeterminate colitis. Now, ulcerative colitis begins in the rectum as proctitis, extends proximally, and 30% of children have proximal disease at the time of diagnosis. 50 to 80% have extensive colitis, and it is less likely to be associated with systemic manifestations. Adults more commonly have distal disease. In pediatrics, in infancy, the differential diagnosis is exclude cow milk protein allergy. Crohn's disease in pediatrics is likely to have extensive anatomical involvement. At initial manifestation, more than 50% have ileocolitis. 20% of children who are less than 8 years can have exclusive colonic disease, and 30% have upper GI involvement. In adults, in contrast, isolated small bowel disease is more common, and in children, we have to differentiate from celiac disease, TB, giardiasis, and foreign body. The extraintestinal manifestations are more frequently seen in Crohn's disease and ulcerative colitis. There's poor growth in about 40%, decrease in height velocity. 90% of Crohn's have it at the time of diagnosis. Joint involvement like migratory peripheral large joint involvement, skin involvement like erythema nodosum and pyoderma gangrenosum, eye involvement like uveitis, glomerulonephritis, cheilitis, and hepatobiliary involvement. Manifestations that are correlated with the severity of disease are peripheral arthritis, erythema nodosum, and anemia. Now, Poddar et al. Have compared clinical manifestations of ulcerative colitis and Crohn's disease in children, and with the exception of age, gender, duration of disease, all the other parameters are more disturbed in Crohn's disease as compared to ulcerative colitis. But on logistic regression analysis, only abdominal pain, weight loss, and anorexia and fever was found in higher proportion of cases of Crohn's disease than ulcerative colitis. Now, in Indian pediatrics, in 2016, Kapoor et al. Reported a flowchart. In a child with suspected IBD, bloody diarrhea is suggestive of ulcerative colitis, abdominal pain, chronic diarrhea, growth failure, arthritis, eye involvement is suggestive of Crohn's disease. You go ahead and do a set of investigations. Then you do ileocolonoscopy, upper GI endoscopy, do a biopsy and come to a diagnosis. But allergic disorders and immune deficiency have to be excluded in children less than 2 years of age. And stool examination is important, and 2 or more biopsies to visualize the GI tract, even if macroscopically it is normal, is essential. Now here are the set of investigations you would do. You do a blood, CBC, urine, calcium, potassium, phosphorus, LFT including albumin. You do a CRP, ESR, and you do iron studies, folate and B12 estimation. Then you do second line investigations. But before that, you have to exclude TB by quantiferon TB Gold, chest X-ray and CBNAT. And second line are serological tests, which I will tell you in the next slide. There are endoscopies which have to be done and imaging studies. In the fecal calprotectin levels, as you can see in the figure on your right hand side, it is unreliable in children less than 4 years of age, because at this age the calprotectin levels are high. Now, the disease severity variables have been compared between Crohn's disease and ulcerative colitis in a publication in the Lancet in 2019. These are clinical, these are serological, and these are genetic. And in the clinical, you would see that limited anatomical involvement is a mild disease. Growth impairment makes it a severe disease, more frequently in Crohn's. Age at diagnosis less than 14 years makes it severe. Age at diagnosis more than 40 years in adults makes it severe. And so on and so forth, as you would see in this slide. In serology, Anti-Saccharomyces cerevisiae antibodies are positive in cases of Crohn's disease. Anti-GM CSF is positive in Crohn's disease, unlike in ulcerative colitis, and NOD2 mutations are seen in Crohn's disease. So what is the treatment from a bird's eye view? It's nutrition, medication and surgery. I'll tell you very briefly about them. Treatment by nutrition involves exclusive enteral nutrition, where liquid diet is given with all necessary nutrients to induce emission, and dietary modifications tailored to the diet to manage symptoms and improve nutritional status. In the medications, we have aminosalicylates, steroids, which are used in children to induce remission. However, long-term use is associated with side effects. Immune modulators, purine, xanthine, and 6-MP, methotrexate to maintain remission, biologicals like anti-TNF agents in moderate to severe disease, monoclonal antibodies to TNF alpha, and antibodies against IL-12 and 23. So these are first line and second line biologicals and antibiotics in perianal fistulizing Crohn's disease. Now here you would see that in this slide the treatment starts from below, from the base of the pyramid, and it goes up, and the less severe to more aggressive treatment, this is a step up approach, and when the patient becomes better there is a step down. In patients with severe disease, dual biological therapy can be used and it has been reported to be effective. So therefore the approach is multidisciplinary. In pediatric IBD, you have pediatric gastroenterologist, you have a psychologist or a psychiatrist, you have a dietitian, and you have a pediatric surgeon, and of course the pediatrician is in the center. Now, what are the differences between pediatric and adult IBD? Clinically, more extensive intestinal involvement in children, higher risk of upper GI disease, frequently more inflammatory and less structuring, more than 1/5 debut with extraintestinal manifestations, and more risk of bowel resection because of stricture formation. Distinctive pediatric complications are growth impairment, particularly in very early onset IBD, male Crohn's disease, high risk of osteopenia with growth hormone resistance, delayed puberty, specifically in females with Crohn's disease, and there are mental and health barriers, for example, mood and anxiety, personality disorders, eating disorders, body image dissatisfaction, illness stigma, IBD induced intrusions in daily routine, and social and academic difficulties. So the threats are risk of cancer because of long-standing disease, growth failure from drugs, growth failure from improper nutritional management, gaps in immunization and infections, therefore, special dietary needs in children. So treatment has induction of remission and maintenance. In pediatrics, we focus on the use of steroids, although I showed you that biologicals and dual biologicals are also being used. It's an if and when required. Treatment is family-centric, and investigations, I cautioned you about use of calprotectin cutoffs because they are unclear less than 4 years of age. So we monitor children with pediatric disease activity indices, both of which are available for ulcerative colitis and Crohn's disease, and regularly monitoring for growth, development, and response to therapy. So I would like to thank you for your patient listening, and I hope you found the session useful. Thanks.